nami amukela eka rihanyo la Dr. Crew. Nongonoko lo mayelana nokubanzi lebyi lavaka na tsona. Kambe eka vanghana va hina va ta yi dyondzisa kusuka eka vana lavatsongo kuya eka vana lavakulu. Kanti futhi lolu hlelo luzonceda kulabo sebenza grade 11 grade 12 abafuna ukuqhubekisa izifundo zabo ukuthi babe odokotela, onesi nalokhu okunye. Namhlanje siqhubeka nodaba lwethu besiqale ngalo ebesikhuluma ngalo last week leli esithi usifo soshukela. Sizoqala ngazo izihambi zethu ukuthi ngobani kanti basuka kuphi. Ngiqale ngawe sisi la.
Sanibonani, gama lami ngokwanda, Mambo yi-dietitian.
Inkomo, vito ra mina ni Eric Chauke, ni tirha as a pharmacist and ni based Dutchman.
Kerebuha, nakin namu kutsumuri mapani, podiatrist orna kamautu, kisinza muna Gauteng.
Molweni Bukeri, gama lami Jimora Nthabile Madoreni, the occupational therapist, and I'm also based in Johannesburg.
Dumelang, Lina Lakatina Regina Mampani, I'm a physician endocrinologist in Joburg.
Singasachitha isikhathi siqale ngaye uDokotela Regina. Dokotela Regina, siyazi ukuthi isifo soshukela sigcwele kakhulu la eSouth Africa kanti si-affecta abantu abaningi. Sifuna nje ukusithathe namhlanje ukusibekela ukuthi umuntu makasenyanga isifo soshukela ngabe nimtreata kanjani nenzani kubona.
Ngiyalebuka. Ge una le bolwetse ba sukiri, go na le a medical treatment and go na le selo se re se bitsang a non-pharmacological treatment. Ge re bolela ka non-pharmacological, re advisa balwetse ba rena gore ba lebelele dilo tse e leng gobane ba di ja. So diet is very important go bona. Re ba encourage gape le gore ba exercise at least 30 minutes 5 times a week. And then into important cover by making sure if banally other chronic conditions, high blood pressure, cholesterol, or chronic to be well controlled, to be well managed. Kemuka only what is known as pharmacological management. So pharmacological management will depend on a type 1 diabetes, type 2 diabetes, or what is known as gestational diabetes. But we have type 1 diabetes because bona have pancreas produce insulin at all. Treatment ya bona ki insulin. So bona if basa humane insulin, ba kona go bana ba what is known as DKA. So ba aba really without insulin. Kimga but we have type 2 diabetes. Bona because of their insulin resistant. So pancreas is going to produce insulin, but insulin is not for the entire bereka. Ba management wagon, kehore rebalfa something by jam for again insulin sensitizer. Take drug and insulin sensitizer. Please take number by jam for again metformin. So bona bakana bastata po metformin. Hey no ba control the English. Back on on just metformin. If by local controlled on metformin, from era another tablet, for intuition, pancreas will produce insulin. You are not known as a dicloside. So those patients back on for re-added to their metformin to ever jump for the dicloside. Came back on another group. Medication known as GLP-1 and analogs, and another group as well known as DPP-4 inhibitors, another group A the glucose 4 transporter 2 inhibitors.
I think Mr. Eric here is a pila or Dr. Regina, COVID ra bona batho bona le COVID bona ba no ke bolwetse ba swekere nka re ditsamaya ke mati ke leme le parking le saliva. So regarding ka COVID le bolwetse ba swekere,
well, unfortunately bolwetse ba swekere bo produce batho ba bantsi to the infections. So if you're poorly controlled, but humana le gore batho ba bantsi ba ile gore ba bana le bolwetse ba swekere ba outcome from COVID mainly poor, mainly because never see controlled, especially batho ba ba le HbA1c tse leng gore di more than 11 ne ba fumana le gore because of that it's riskier for they are immunosuppressed from the diabetes, so the outcome ya bona ne le poor from COVID.
Dr. Rijani. Mr. Eric, as you said, you are a pharmacist. Key pharmacist. Libereka jwang kanti utsi yasiba kasisikanangana ngoba pharmacist.
Okay. A pharmacist is a healthcare worker or a healthcare professional. Mainly the focus here training is into the main disease states that are happening on a human being, but the basis of training on so the main part ya pharmacist ikutiva kwenda miri, and then ukutiva kwenda miri leyi ufanele ukutiva kuyitira njani emirini wa munhu, ufanele ukutiva ku uyiendla njani yona, meaning kuyaka production and make those tablets leti Dr. Abraham left off. Training yakona yi take 4 years of full-time training at university, and then after so now we enter internship, and internship yakona may enter a specialty or may enter even in a manufacturing setup, and then we enter na community service internship after that na community service. So in short, that's what a pharmacist has to go through. Ufika stage as a pharmacist, which means it has to take 6 years by the time we as a pharmacist in the community. Kuna different fields that the pharmacist one of them the manufacturing industry, PDC and produce it. And then the next level in hospital pharmacy. So the pharmacist can be government hospital or private hospitals. Then another sector which we refer as retail pharmacy or community pharmacy. Pharmacists within the communities. Some of them operate in shopping centers or right within residential areas, and then the last one into academy, but train more new pharmacists.
Dr. Rijani ubuletsika type 1 mobile insulin, which is injection. Kumele ukuhlamisetse gore ibereka jwang injection e. Haitsena omile kanti di fapana byang hape le di injections tsa type 2 di injections tsa insulin tse tsa hospital he motho ana le sukiri entshi a tsena hospital re tsa di drip di fapana byang di injections.
Okay, yeah, so insulin as is the main hormone you put control sugar is that insulin. So type 1 diabetes meaning producing enough insulin to move sugar from engatini to the cells around in your body. So for Banbala also that's where insulin. So in other words, you are boosting the the insulin levels in wa patient jaleyo. Once over injected that insulin, you move the glucose angatin into the cells so that a lower level or like a level that is expected for a body to function with. So those, I would say, those are the main ones that let's develop the receiver in on patients.
Doctor, let's have a pills, metformin, especially metformin. Metformin. Okay,
so Metformin ya imapilisi lawa yatirhiswaka depending ka level ya vuvabyi. So kuna like I said, the way dose work hi kona kuna vanhu lava va a low dose but va yi like 3 times a day so that va kota ku maintain a good level ya yona engatini, kasi kuna nkarhi la dose ya kona yi va ku much higher, and then munhu a kota ku yi tirhisa kambirhi a sikwini instead of 3 times a day, and then in some instances kuna leti slow release metformin tablets. So yona as it does sensitize the uptake of glucose from the system, so improve the ability of humesa glucose from lying into the cells, and then it delay absorption ya chukele from like acquiring that absorption which is the intestine delayed. So in other ways we don't have too much absorption of the sugar into the blood circulation. So those are the main ways that and then also the actual you prevent an shibindi from produce sugar into the system. So most of the time there are different ways where your liver produces glucose or sugar in your blood system. So with metformin you block that process. Block that process, you also sensitize your system to be more responsive to insulin, and then on the other hand you delay absorption. So in different ways, and that's how patients are benefited by it. And it's one of the old medication it's still very useful.
Believe metformin maoto a ka thoma a methodiletse mo or he ke nwa metformin nkare ke tlo ba di renal failure ka speed o ka renga metformin ko bathong ka teng.
Yeah, metformin the excretion you find by which is the kidneys. So obviously, because the excretion is through the kidneys, the likelihood is that at that point you the fingers into metformin, you damage at the kidneys. But normally, the test that the creatinine level in a patient, which determines how the level of excretion or the functioning of the kidneys. And obviously the patient any issues with the kidney functions but who are treatment monitor. For Munoi already a compromised kidney function, but that are going to test that more often, times 2 to 4 times a year. Because normal kidney issues still by monitor to make sure go expose more other additional problems or health conditions.
Mr. Eric, is there a mechanism metformin the weight loss? Because the patient, weight.
Well, in that case, I think that's obviously the belief is one but I think it might be driven by the fact it interferes with the glucose usage. So when a problem you have to digest that glucose well yourself, and then you go in and interfere again with your glucose management. The likelihood, as we know, kuri chukele logoringa absorbwanga amirini. I mean, logoringa in abundance that and move over into your cells, it gets stored as energy, and whatever is stored as energy, it ends up becoming the weight gain that we see. So, the likelihood is that when connect those kind of mechanisms with local, even if I start interfering with that part, it means I won't have more of the sugar that is piling up as energy that is not used. But I should honestly, most of the medical personnel should encourage that because it can be very harmful. There is a risk also if your glucose control and then you start interfering with that, drop sugar to levels that you think are more harmful for your body.
Sekukhona le treatment entsha dokotela lakhuluma ngayo lana ungabe usithathe yona ukuthi isebenza kanjani ngoba nokuva ukuthi ngathi yona i-right uma renal failure iya protect ukuthi ungafiki ku renal failure iya protect ukuthi ungabi nabo cardiac failure isebenza kanjani le treatment entsha yoshukela.
Okay, so I hope the sodium, the SGLT2, the sodium glucose co-transporter inhibitors. So those ones, the relevant is that they actually increase more the excretion from your system into the urine, because obviously this was from the kidneys. So that way it ends up assisting more in terms of regulating your retained sugar in your system, and and it has been claimed for chronic kidney diseases it are more helpful in protecting the patient.
Wow. Mr. Ndlovu, njengomuntu ophile nesifo soshukela esikhathi eside, ingabe wena iyiphi i-treatment oyithathayo kumanje?
Khona manje ngithatha i-Lantus.
Umjovo. Okay.
Yes, metformin ne-glucophage into eyi-1.
Yes.
Sekuya nekhampani eyi-producer.
Yeah.
So ngiqale ngayo-glucophage and then ne-dimacron.
Okay.
Zizama
Yini dimacron lapho Dr. Eric? Yini dimacron?
Well, it's an oral antidiabetic. You put in terms of the control of the sugar in your system, and also encouraging the insulin sensitivity.
So every time when you take metformin, you have to take it with another drug.
Yeah, usually we combine because of the material we are different. So on one side you are stimulating the insulin responsiveness, which you also do get, by the way, metformin with sensitizing your body to respond to the insulin that, the minimum that you've got in your system.
Okay, that's good. Then
and then asuka lapho default athola as i-sunseeds.
Oh.
Then nazinga-sunseeds bangifaka ku-injection. Ngayithatha le-injection nayo ngaqhubeka nokudefaulta yanga-sunseeds. Bafaka enye injection engabona ukuthi manje sengizobulawa imjovo. Ngaqala
ukomply.
Mara kwamanje ngithatha 2 imijovo. Le enye short stay, and then le short active, le enye long active. Lantus is a long active,
yeah.
And then awungibaleka
Wow.
nevoropiti na ile uyithatha ngaqeda ukudla or before ukudla ukuthi lo kudla kungenzi next life
Babendlovu mani uyayazi lento mani uyazi ngisho ukudlula kudokotela ngathi zoba i-ambassador yesifo soshukela kumuntu Mr. Eric nawe uyayibeka abo-short acting long acting kwenzakalani manje ngale mijovo yabo long acting nabo-short acting
Yeah, going like the long acting, at least it's something it's got to do with the half-life. So the half-life, yeah, that kind of product, you buy really much longer, you got a controller for Garole, and you know, the way Munangare Kujeni, Swakuja, Garale, Okumaku, your sugar level, you buy maintained to a certain, you know, required level for a diabetic. Because the short acting as the done of Abula normally you get your postprandial where your sugar sort of like picks up after the food, and that's where the product those short acting, but they are rapid in terms of their action. Because the actor a bit slower but more steady for a longer period. That way we got to maintain the sugar control yamubantu.
Namhlanje sichazelekile ngemijovo ne-treatment yoshukela. Kanti ngaphambi kokuba siye kulaba abanye Mr. Eric, ngifuna ukubutisisa la. Uma ngabe umuntu ethatha le mijovo or amaphilisi oshukela elinye neliphilisi siyazi ukuthi line-side effects. Ngisho ipanado ungayithatha kuba khona ama-side effects. Njengabanje ngoba bakhala ngomjovo immunization le-COVID ukuthi kunama-side effects. Yonke into esithatha ngisho le-brufen ine-side effects. Yimaphi ama-side effects wale treatment yeshukela kanti especially lawo ayi-life threatening?
Okay, I think earlier on, Dr. who had up conditions like acidosis. Yes. So kuna mapilisi one ya trigger such effects, and which can be quite harmful to the body, and also can be lethal. I mean, they can be deadly if they are not managed well. Like you're now with the lactic acidosis because of that rise in the lactic acid or the acid in the system or the serum, and then but in addition to that, respiratory distress that can be seen, and then other effects which may not necessarily be that deadly, like your gastrointestinal one. Kasi kuna mkarimwan la muna abago into some of the medication they think abisaga into a hypoglycemic level, so ila say chukele bago retrope kutulambi then which is not needed and it needs to be managed properly. Kuna I think like when you get keto, I think it's what ketoacidosis. Also, some of these sodium glucose transponder products can lead to some of those kind of conditions which needs to be managed carefully. But one of the bigger ones, I think, the acidosis usually, in most cases, if it's not properly managed, it can be, it can lead to fatal outcomes.
Mr. Eric, ngikeni lapha ekhaya uzuvele kabanzi nge-treatment yokulapha isifo soshukela. Sesingena lapho-ke okubaluleke khona manje la ey'nyaweni. Mr. Ndlovu, uke washo ukuthi uke waba nesilonda. Maybe before kuba nesilonda bekwenzakala nje la ey'nyaweni zakho, yini mhlawumbe into okuvame ukuyiva la ey'nyaweni zakho?
Hayi bekulunga kodwa ngithola ukuthi kukhuluma kamnandi nje. Nawe kuyaluma lenyawo kodwa nawe lokho libamba ulithi hayi kumnandi kanti nawe lokho kwenza kanje uyazivula lezi
Awu.
then nasesivulekile siyaqala manje sichitha ama-fruits sicala ukuba painful and manje lokunyathela sekubanzima ukunyathela nje kubanzima.
Mr. Efi, kuwena podiatrist.
Yes.
Ngikopela ukuthi le batho high kini podiatrist itse asibanga sisikanakana ngoba podiatrist kanti libereka kayini lena.
Ngiyaleboga doc. So podiatrist ke ngaka medical professional o sebetsang ka maoto enkele mangwele le tsheko sometimes ba bana se sebetsa ka maoto fe mara de o tsamaya ka teng for example ke tsa tsheka la go le go tlhoka mangwele so sebetsa ka maoto jaaka papana ba go nana le di ntho go maoto di ntho maoto a tshesang a batang a go kgang ba bang ba ngale maoto fela basics le go ga maoto go fufulela ga maoto then gape go na le rona ba ba sebetsa ka di athletes le go na batho ba mathang rugby players soccer players and then le ba na ba sebetsa ka bana ba sa le banyana like go ba le go tla go futela tsolo ngwana tla bile a se se ke podiatrist a fele tsolo orthopedic wa go tse thusi sa duminyana and then podiatrist mo Africa ka ofela is study ko UJ. So some of the subjects into West Medical School like pathology, but the main University of Johannesburg, Africa, in 4 years, and then in work-based training. So from second year, one patient to clinic, Joburg, Jen, Tabu Memorial Hospital, Bara, Helen Joseph, and some of the local clinics. The students from second year were already patient until 4th year. Then from there, I registered as a professional counselor or practice separate.
Okay. So when that thing to since I believe so great, Mauda high na since I told abonsa matatamon. Lena is podiatrist. Kemi neto ati. Horo mutana li kubeti basuke. Otanza li bone ni. Tanza li bone Henry Luana or Kinano ya fela mo podiatristing. Just for Maudu or especially by basuke. Utsonze ba ke mo le na leng se tsaba bona iso ka bane
go doctor khelo go sebetsa sentle because remember to get a teamwork.
Yes.
So that they have to diagnose you ke doctor high doctor tshwanetse a bolele gore to get a affect amount wa ha on the day at diagnosis tshwanetse a bolele gore optometrist podiatrist dietitian so gantsi the patient that I have a bolele na bo mo tsokela gore that have fitla no diagnosis ba so doctor o focus the mo so some of those conversations are every day. And then, so, from the get-go, I feel to diagnosis, that's why I'm podiatrist. Then podiatrists are for education. Well, Papa Kalat's if now podiatrists ask why. Education it was before our problem. Isn't after our problem. Hold up a ask because I remember the to affect the map. So I feel the matter of Catalina, who can make the maths. So the educational responsibility from diagnosis. And then here after from there, if as not complication, what is a year? It's good enough for every year I feel education for example, to get a cheese, how bad? I don't know to the hygiene eating, or never tell a lot of needs of the usual. I don't know some barefoot to so but only in Europe, I tell you for the how we see. So, how does a member mouth? I can tell you again something as we see. As a woman, I don't know how will you be. I'm not as low as a laboratory. If Mutumu go to Mabona, why is it? That's why I can tell you that it is to inspect mouth everything happens to car. So, that's what I know. When I diagnosed to dog, second nurse or part of the treatment plan in the education also to what I come. And then before we another thing is most of the diabetes actually my diagnosis identify podiatrist. So it's a silent killer. So have to diagnose normal cheese or abata or the Atlabata, Dr. Labata. Abata because of podiatrist in South Africa, if we get a name. this could be diabetes. Then to go to those questions about what can come out of and then we refer to doctor will diagnose, and then between another doctor, that's when you build the team, like one of the dietitian or optometrist, and that's how ideally what else is the situation.
Dingaka go high, dingaka go dipetlele, dingaka go ditleliniking. A re ithuteng go refera balwetse ba rena go di-podiatrist. Today ke ithutile tse ngata ka podiatrist e ne ke sa tsebe ka yona gore e important ka eng mo maotong. Ke utlwa a bolela ka gore go na le peripheral neuropathy ya gore batho a ba sa utlwa maoto a bona, and nna ntho eo ne ke itse gore e naganfa ke di-occupational therapist. O ka re botsa gore ke eng occupational therapist kante gape le bereka jang, especially mo motho wa diabetes. O ka reng ko rena dingaka gore tshwanetse re ba refere go lena neng?
Occupational therapist is a health professional responsible to assess and then treat and manage any occupational dysfunctions as well as any physical conditions or mental or psychosocial conditions. So which means that a lot of times, though, abantu they actually present occupational dysfunctions more than the conditions themselves because they don't have a clinical inclination. So I was driving and then I started feeling a discomfort, or I started going to the bathroom frequently, or I started getting disoriented, or blurry and so on and so forth. So those are occupational dysfunctions. So in understanding that, unless we are fully occupational, then we are not healthy, because someone is not going to say, I think I'm diabetic. They'll say, suddenly, I is scoring and cause magama. So those are the occupational areas that I am referring to. And then on the issue of diabetes, most commonly, all the khabadins, which means about they would want to refer to occupational therapy and physio right at the tail end when patients have sustained what you call secondary complications of diabetes. So when there's already an amputation, when there's already a visual impairment, either mild or progress in terms of a patient sustaining secondary complications. And specifically with diabetes, to say that all of these things. The moment a patient is diagnosed with diagnosis with diabetes, there's a change in their routine, there's a change in their occupational profile, and the patient must take an active responsibility in terms of managing the condition. So in progression in diagnosis in diabetes depends entirely on what you call an active role by a patient. There's a term in occupational therapy, we call it DSM, which is diabetes self-management. So unless that person monitors their glucose level, unless they take their insulin, unless they're compliant to their diet, unless they monitor their glucose on a daily basis, they're not going to be able to manage the condition. So when occupational therapist comes in then, is on the motivating aspect, to say that because patients do become despondent, we were relapsed several times. There's a term in our books that we call diabetes overwhelm. Procedures, is a distress. So there is someone who's going to say, let me look at your occupational profile. Let us see within your daily activities how they will factor in this new you who must keep you alive. Does it make sense? So you look at the activity profile and say, you can also be active whilst you on drug, so that there is that weight loss that has been prescribed by a dietitian. So and also the issue of the psychosocial component of being diagnosed with a chronic medical condition. Right? So we then come in, so issues like group treatment, where then we expose you to a greater team who has been in this journey, and the fact that there's what you call altruism. So if Unayolendo and universality, I have been diagnosed with diabetes, I've had ABCD, and this is where I am now. So an occupational therapist is then going to facilitate those group therapies, because the psychosocial component is actually always left behind. No one wants to find out how are you interpreting this chronic diagnosis, that you've just been given, but want people to comply, and you don't understand what are the psychosocial aspects that make people not to be compliant into their own medication. So as soon as you get this diabetes, you say, what now? What do I do with my daily activities? And it's quite interesting to say that within the South African model, only less than 2% of diabetes referrals are taken to occupational therapists at this stage. So the greatest number of referrals would then come in when there is legal that you can do in terms of stagnating the condition, but now we're already compensating for permanent loss functions.
Wayibeka urithamile i-occupational yacaca. Ngiyathemba ukuthi nathi sibodokotela siyafunda namhlanje ukuthi kungani kufanele sithumele ama-patient kuma-podiatrist, kungani sifanele siwathumele kubo occupational therapist kusese-early kungakabi nama-complication. Babendlovu, uthishela une-renal failure ufanele uhambe kuma-dialysis, kuyi-affecta kanjani umsebenzi wakho yonke lento?
Hey, iyafekta impela. Ngoba kwesinye isikhathi akufani uvuka ukhathele, umzimba ukhathele, akuvumi ukuthi usukume yebo. Manje iyafekta impela.
Umsebenzini usaya kwenzakalani manje?
Hayi, umsebenzini ngine-2019.
Bese kuyisikhathi sakho sokuma noma bekuyilokugula?
Ngoba isikhathi sami sokuma kulo nyaka kodwa ngine-2019.
Phethani sinceda kanjani ukuthi umuntu aqhubeke manje azawufika kubo 65 ayekele emsebenzini because sokuyi-pension angayekeliswa ukugula sibanceda kanjani?
Enkosi sisi, ugqirha bekhe wathetha apha uthe eSouth Africa we have about 2 million people who are known, who are diagnosed with diabetes. So if we can take those people out of employment, when we have a crisis of unemployment, we're just exacerbating ingxaki esihleli nayo. So there needs to be people who are going to intervene to keep people as employed and as functional as they can, or for the longest time, because they are able to then the livelihood, the income emakhaya. Now, where we come in then as occupational therapists is that there is no one size fits all in terms of functional recovery. So what is important that we do is to conduct what you call a functional capacity evaluation. So you cannot say, wonke umuntu one diabetes, this is for how long they'll be able to work, or these are the challenges. Any person has got their own story, and the functional ability is determined not more than by the clinical condition itself, by the other issues, psychosocial issues, how much is the motivation in kaya, who and all of these other issues. So you can therefore say that diabetic, this is how you then go to structure their work, and individualized functional capacity evaluation becomes critical. And also activity demands of a teacher is going to be different than that of a doctor, and then that of a driver, and then that of a policeman. So you must then understand, what could be reasons for occupational dysfunctions in diabetes, right? So there is conditions like neuropathies, which have been explained in detail by our colleagues previously, and then there's issues of issues of fatigue. So an occupational therapist is going to determine the physical demands, the cognitive demands, are you in a mental state, and then the social demands, because people have got their own stereotypes and perceptions around certain conditions, including diabetes. Do you understand? So the moment you sit about doing they will come with all of their theories and everything else. So you then need to empower a person to say, so not just the physical issues, to say, if you're working for 10 hours, you can do this job in an alternative manner and and almost alter it. We then need to look at the psychosocial components of that job. How do you empower a person to be able to respond to all the perceptions around diabetes? If someone suddenly opens an article about people dying of diabetes, and I'm seated here and I'm diagnosed, how do I receive that information? So us preparing people or assisting people to remain employed is not only limited to the cognitive or to the physical aspects of the condition, but the psychosocial and the social components of a condition. So a functional capacity evaluation for each person becomes critical because there is a different approach in dealing with our patients.
I-diabetes akusiyo ekhiphela emsebenzini ngeke ikhiphe.
Okay.
Inayiyodwa ngeke ngingaqaluza 96 kodwa icala ukuhlupha 2019 ngoba sekuvuleleke lamanye ama
Secondary issues.
yabona sekune high blood sekune renal failure and then lezo ke manje nohulumeni akasavumi ukuthi uyosebenza una utreat ama chronic I4 ilokho umhlanje not i-diabetes
I-diabetes
uyaqhubeka nokusebenza
uphile normal.
Yes.
Ngiyacabanga niyavakalisa emakhaya. Kanti-ke Rithabile ngifuna sicacisela. Umuntu besisebenzela ekwazi ukubona lapha nalaphayana akwazi ukwenza 1 2 3 kunganamaphini nendlela enyaweni lokho especially ukuthi uthola ukuthi akasaboni kahle so nabo retinopathy so ne-dialysis njengoba-ke wonke lama complication unawo nimnceda njani futhi as occupational ukuthi abe independent.
Okay. Again, it's very important that understand the visual impairment to what extent is it? Because sometimes you don't want to compensate for the function that is not lost. So there is a room for you to then refer back to an optometrist or an ophthalmologist. But once you get a diagnosis or a prognosis that says that we've almost reached a level where there could be an improvement, then you start with the compensatory technique. Now again, you need to analyze it because sometimes if we're speaking about visual impairments, certain jobs have got different visual acuity demands, right? So for instance, me as a plumber or me as someone who's a seamstress, my visual acuity demands are different than me being an administrator. Does it make sense? So there needs to be more focused in what I'm doing in terms of my eye issues and so on and so forth. So you need then to understand in Yoga, if there's a visual impairment, what are the visual acuity demands for this particular job? And therefore the treatment then, or the compensatory treatment is going to sometimes be based specifically on those demands of a job. And sometimes our affected in sometimes, even though you find that then the left eye will be more affected and then Elingi Mehlo will then join in. So it's very important to save the non-affected eye.
Yeah.
So our compensating for both, hence that assessments then become critical. So you don't expose them into an activity wherein if it's going to then start having issues. Does it make sense? So it's very difficult to respond to your question because your question would require an individualized assessment to say when's Adoni and what is the extent of your pathology or your impairment. Same applies to neuropathies. If there's a nerve impairment, which is what you call, I think one of the doctors explained this as a microvascular issue. A nerve, you can have a diminished sensation. You can have a total loss of sensation. So because of that, in other issues, you are retraining the impulses as an occupational therapist because there is just a damage, but there is no complete lesion. But for others, you find that the hypersensitivity or the irritation which is found in neuropathies or in the olden days when we could not manage HIV as complications of certain antiretrovirals who get you neuropathies, that's just a hypersensitivity of a nerve. And your approach into treating that is different from someone who has had a total lesion, wherein they are unable then to have any sensation. And an issue where there is a complete lesion in that nerve, the issue now, which is a direct focus for us, is the issue of safety. Because the luminous are the ones that protect us, right? In fact, that pain sensation or whatever sensation that you receive is the one that tells you there's something wrong within your body. So issues of pressure sores and all of these other things because of bony prominences, I will say that I must actually change my position. So the education that says use your eyes. But in areas where it's in the back, where your eyes can't then compensate, there's other techniques that you use. So the issue of assessment becomes critical because in some instances, you don't want to compensate for a function that is not lost. If there's just an impairment in the nerve, you'd want to retreat and redirect the impulses. But where there's a complete neurological damage and there's loss of sensation, then that's when now the compensatory techniques comes in to say that instead of doing A, do B. So you're no longer now retraining the impulses to reinterpret the altered nervous systems.
Kuyevakala khulu. Tata sisabuletse mo hore maoto na tsulesiso. Lina as podiatrists. Diwana nyaka treatment ya nina yana. Or liga kama maoto.
So treatment ya maoto fa tsulesiso. Patient are referred or isolated. First, the cases of remember neuropathic ulcers. Maybe patient have feeling. Then diabetic ulcer where the sugar was high, patient may develop up this, especially in the big toe. And so you have to identify, sometimes it can be a vascular. So because neuropathic ulcers, then vascular ulcers where there's the artery block. So first thing to identify why it developed. Develop is tweaking relevant at the site of the wound. So for example, you have Papa Nelika. So if you look at it means for Papa kidney teacher. So the type of shoes that Papa roll out, because they do need a cushioning. So is the wound infected? The wound infected, sometimes you talk about IV antibiotics or once you control that, the most important other thing that we need to why it developed was the sugar high. Because remember, Ebola nerves, Ebola attack, that I cannot diminish vitamin B12, which is very important. So, Papa, the referring doctor, or if some referral to address it, then we can not only particularly the hard skin around it, the bride, take it with the bride around it, because I don't have to move for like physically like the infection, then right dress. Then patient normally it's a very expensive thing, that's why the patient didn't need her. Because patient will often say initially they are half meters, so that's taken after every 5 days. And then once you can develop a wound diabetes, chances of recurrence they high. So chances of it will develop a high. Yes, so that's why now after if Papa Arang that's in the wrong, we can make insoles, the cushioning. So that at least, because I know all of us as we age, the head around the foot affair. So the big sure now to get it was we make sure we protect the foot. If not 5 hours a teaching. I only had leather or I don't know, maybe we need to get only diabetic shoes, only take it, we can make cushioning, the float in there, you can have pressure. So that's how we would do it. But now from there, that patient then already over high risk because chance of recurrence is high. And I remember the other reason why I want to treat these wounds is for the issue of amputation.
Yes.
So that wound can get infected over septicemia. So the earlier, the better. And about one problem of the heart develop a wound. Now we know that the wound or thought that what's happening or everything to them, but I'm not fully shaped there. We are going to be. We are going to understand? And then Batabo when I join, first holiday. And sometimes the other thing is the other stigma. What develop these wounds, they smell young. They affect the relationships about in other families to Zawara in a different because a high young because some has intrigued. So all of the psychological aspect of it. So most of the patients it actually if you're diabetic or walking a small thing. Rather, we are clinicking or doctor how rather is nothing than for Emma, especially when that sometimes even though we want to prevent amputation, sometimes amputation is the best solution. Because if we have a big toe, we protect the second toe, the third, and we protect the chance. So sometimes you know here there's nothing, there's wet gun, the ring is finished, why is and then happy to that we always work with vascular surgeons so that they need to check what is there. Because I believe it's a whole plan of treatment, develop prognosis. Can this heal? I always tell my patient this can take 9 months. So from the get-go, you know this is going to be a long time. In that 9 months, what are we going to do? What's our first plan? If fungal infection, then I go to infection, then I go deal with pain. Because some of them actually have a sick wound, they actually pain in the wound. So there are those things, and then we treat it. And then I always tell the patient, always want to get on. I hold a doctor more fasting into some patient that together, if patient that together are issues. Because we can come, I can give you the most expensive home dressing material.
Yeah.
You are setting me back. So when it comes to managing these things that you can get teamwork, and I tell my patients you are a doctor too. Because I didn't know when we can sit there like doctor, I'm on medication 2 days before I go consult. And then another time you check this patient is fine, why would this afford? So that thing about the patient is that's what people don't be health professionals, they don't tell more how dependent we are dependent on each other. Understand? And then another thing that they want to is wounds. The patient there, the trial, honey, people try homemade things. But what do you consider? How somebody that's saying time is massive. You need the sooner we corona, the better for you. So the wound is and then another issue because moments are well neuropathy when you don't feel anything. So even if your shoes are tight, because most people make a mistake in the morning, but you should actually buy your shoes in the afternoon. That's why most people have a meditation child actually tight about so that actually this is not size. So all of this first I assume greatly too tight. Some of the matters are not console or how that friction from the attack to develop a wound. So that's the other main thing is to Yankilia, but I will make Baba and all of those things. But you buy a shoe you don't like the first time. So as a diabetic, those are the things that you should avoid. So what are you in neuropathy? How will I say and then global problem
ezempilo zwamutakalo iletha isifundo esikhulu ebenami bengasazi ukuthi ukuthenga isicathulo umntambama kubaluleke and shopping sithande kuseni mos so namhlanje sifundile kakhulu ake singene la ubabendlo ufike washo wathi ukudla kufanele adle nabaningi nodokotela nje bashilo last week ukuthi kufanele udle kahle exercise sisinokwani
yebo njani
ngiyaphila njani sisi njenge dietitian ngicela uchazela abantu ukuthi mina as dietitian nama nutritionist ngihluka kanjani.
Okay, ngiyabonga dietitians nama nutritionists umehluko, the biggest thing is ukuthi dietitians work more in a clinical setting, so that's in hospitals, doing therapeutic nutrition, so dealing with complicated nutrition related conditions. Nutritionists, on the other hand, would work in the community, so at population community level, where most of the time they are educating or advocating for nutrition-related concepts, depending on the community, what are the needs of the community at the time. So that's really what a nutritionist is. But I have to say, Uti, a nutritionist cannot be a dietitian unless they study, of course, right? Study dietetics. But a dietitian, automatically, by being a dietitian, you also qualify as being a nutritionist. So by this I mean, Uti, as a dietitian, I can work in a hospital setting, but also if I want to work in a community population level, that's also possible because I have Leo accreditation. You'll find that some dietitians RD, some RDN, meaning the exact same thing, but you are a dietitian and a nutritionist. But a nutritionist, you always just be a nutritionist. There's also courses that you do online, or about women courses in nutrition, nutrition coach, or all of those things. Yeah, but those are not nutritionists really. There's like a new law which you can't really use words like that. So yeah.
Okay. Njengoba usucacisile ukuthi mina ngisebenza kanjani, ngihluka kanjani kuma-nutrition. Umuntu onesifo seshukela njengoba ngitshilo. Ukuphi ukudla kufanele akudle? Iyiphi i-breakfast afanele ayidle?
Okay. It would need a consultation. It's an individualized thing, right? So, as a patient, what's it? Okay, diabetes, of course, is your concern, but what's your religion? What are my traditions as a kaya? What you celebrate? What is activity? Like occupation-wise, what's your activity level and all of those things. So we look at those things and then we draft a plan for you. So it's Kune now, it's into consultation and go on. But essentially, in a nutshell, it's always a balanced diet. Whether it's like breakfast, lunch, supper, or snacks in between, it always needs to be balanced. When it's balanced, I'm talking about a diet that consists of food groups, starch, there must be veg, there must be fruits, there must be proteins, there must also be the good types of fats. So to answer your question, for a balanced a breakfast for someone who is diabetic, definitely needs to incorporate all of those things. So it could be you are having a sandwich for breakfast, maybe, or even if it's lunch. Always make sure the starch sample needs to be whole grain or whole wheat, brown starch basically, right? Because you need that, it helps in regulating your sugar levels nicely. So it would be your nice bread, make sure that you have a veggie, and then you can have a fruited and maybe put in an egg into your sandwich or any other protein, like inyama, or put in fish or any beans or things like that. But essentially, you definitely need to consult with the dietitian, not just because your friend diabetic and for breakfast, because it's going to be a problem. And also another thing is portion sizes. Just because your friend only breakfast and with bowl and doesn't mean you should do the same thing, because you are different and dietitians are going to be different.
Okay. Usabamba la uma-fruits. Ngicela sisingene kuma-fruits. Kukhona nama-fruits vele sazi ukuthi uma umpatient diabetic awadla ushukela uyinyuka. Imali lawo ama-fruits ongathi mhlambe ama-patient ane-diabetes kufanele bazame ukwa-avoid. Ngoba lento iyahluka. Siyazi ukuthi kukhona i-fruits libalulekile for ama-kidney. Kube khona i-fruits ukuthi idamage ama-kidney. Libalulekile for inhliziyo. Usibalansa kanjani lezinto umuntu onoshukela bakithi? Yazi kuba nenkinga kubantu onoshukela ukuthi babhalanse kahle ukudla kwabo.
Yes, definitely. That's why it's important. So once you are diagnosed with diabetes, ask udokotela wakho to refer you to a dietitian. But if you want a dietitian, you can always go to a dietitian and then also in that way. Now with fruits, all fruits essentially are right. You can have fruits. It's okay to have fruit because they contain so many nutrients or and they're great. But with the diabetes, encourage fruits then the more sweeter types of fruits. Or alternatively, what you can do is try and get fruits like overripe, because those tend to have a higher amount of glycemic. I mean, as you should try directly. Then if they as we say ripe that much, and they contain more fiber, which will help to regulate your sugar nicely. Also, I have to mention also fruit juice. Fruit juice is fruits, it's like fruits, is the enjoyable juice. But it's going to be very important for us to try and dilute the fruit juices whenever we are having it. Right? So if you are having a glass of fruit juice, always make sure you take half of the glass is water and the other half is always the fruit juice, because it contains a lot of fruits. Can you imagine like a glass of the orange juice, just one? It's more than one fruit that makes up that orange, right? That glass of orange juice. So it's a lot of sugar all at once, and it's going to affect you. So then that means it's also, if you're just sitting, it's a normal danger with when you want to have fruits, don't sit and then say to fruits, 3 fruits all at once, apple, orange, banana, all at once. It's putting too much sugar all at once, it's going to sugar straight. So always have 1 fruit at a time. Yes.
Ake sikhulume la ngama-processed milk, processed meat. Umuntu onesifo soshukela uyawadla noma akawadla, and ngicela ukuthi bacacisele abantu ukuthi masithi processed meat sikhuluma ngani.
Yes. Okay. What I normally tell my patients first, what are processed meats? Processed meats will be any type of meat. Ultimately, we are sedentis. Right, you're not sure about the body part, from which body part of the animal it comes from. For instance, like evos, right? You cannot say when I'm having evos. Of course, you can say it's beef, but you can't say it doesn't come from the shoulder, it doesn't come from the leg, and all of those things. Because in the factories, what they do is, but after that, bits and pieces are saved off the meats. They are processes some more, add more fat, add more sugar, add more salt, all of those things for taste, acceptability, so when you are eating you're already taking in very foods that we are trying to avoid for your own diet. So in terms of processed foods, we really please try to avoid processed foods. Processed foods could be evos, could be Russian, sausage, Vienna, beta patties. Yeah, the list is endless really. Even meat counts as processed meat. But if you can choose the lean type of meat, it means that that's a healthy alternative because and they remove the fat, and the fat is something that we're worried about. But of course, uswai and other additives are also still there. Yeah. Okay, but even even polony is not the best thing. Okay, ham even is not good. So basically, mawibuka lenyama, ungekho sure to come from which body part. It's a red flag.
Kodwa manje sebenkinga lena sho ukuthi lo muntu angeke asaye emahhotela mos. Enjoy life mos.
It doesn't have to be that way. I mean, 2022, yes, 2022. Restaurants, they know people are more health conscious. People want new things. They don't just want inyama, they want a certain type of meat, a certain type of cut of meat. Even with bread, rice, most people are sometimes rice at the basmati or brown rice.
Basmati is safer.
It's safer, yes. Even all brown rice.
Okay.
Yeah. So what I'm trying to say is most food establishments already tend to cater for different tastes or different preferences in diets. So if you just ask, what's high goal? Mina actually alternative, you find most certainly they do. Just ask.
Asithi njengoba bendlovu nje unefamily unabantwana kuyathenga igrocery kuyathenga ama-ice cream uthi ifamily advice ukuthi ithenge lezi zinto noma nabo kufanele vele kungasathengwa la endlini nje sonke sibe diabetic ungathini.
It's always nice. I always believe, even it's always nice to see family or support. Whatever means. So yes, it's difficult to bomb about the change in their lifestyle to accommodate you. So I would advise family to try, right? But also now as a patient, as Podiatrist said, if you as a patient, you are the doctor. So as much as a kaya, they can be buying more ice cream, buying all of those things that don't take. If you need to also then make a decision, you say, no man, I'm doing this for my health, for my survival, because I have these and these goals. And
Sibonga kakhulu sisibanda. Sesigoqa nje uTeric. ngifuna uvaleleke ababukeli emakhaya ngodaba lokuthi sihambe soyenza ama-over the counter medication while anesifo seshukela ukuthi ungabaluleka uthini laba abathanda i-over the counter medication.
Yeah, most of those medication, the over the counter is safe, and the figure level labor classified as over the counter if used properly. So the main thing is that they need to be used properly. The overuse of some of those drugs, especially without consulting a pharmacist. So normally when you've got problems, let's say it's a pain issue that you've got, then try to engage with the pharmacist, explain your conditions also, so that Agota could decide on what to recommend for you and what dosage to use. So I wouldn't say go every over-the-counter medication it's harmful, particularly if you registered. Maybe I should emphasize on that because you do find some of the complementary medicine that evaluate in SAPRA, and they do say so. Not able to say this medicine hasn't been evaluated by the regulatory authority, and most pharmacists would take the pain to familiarize themselves with that, or comfortable to give them out, and wherever feel this is likely to be harmful for you, they will advise you otherwise. So challenge intervention a professional, so they just pick up, put it in the box, just because maybe they just join up onto that. So yeah, the main thing is to consult, even if it means waiting a little bit of time to engage with the pharmacist on duty there, rather do it that way than go to the DIY, because I mean the other thing that happens, which we do find a lot, with patient care pharmacy, they've already done a Dr. Google kind of search thing, but diagnosing the owner, and then when they walk in there, they just want what they've read about it. Because if they can engage, there's nothing wrong to say, I've Googled this, am I in the right track or so, then because you allow a trained professional to evaluate what you want to use. So, yeah.
Okay, your advice.
Okay. Whole neglected. On the first basis, things will happen every day. So if you have a family member who can help you cut the nails, you can help them. Then the patients because speaking happens dry, hard, so if you don't know the problem, you can see a podiatrist, sometimes 6 weeks, 4 weeks consultation, you come, you don't cut. And then here people don't moisturize the feet. So so cream even under the feet. In between because moist the whole, but under the feet every day. Diabetic inspect every day. Socks. Because some of these shoes crooked and jones so so please don't already and the socks are like cotton socks because they're breathable. So you put on cotton, they sweat. And then if winter, you don't expose your feet to heater, double socks. Then we expose them out to a heater. Even extreme cold, because even out to fella who tie them over winter because blood supply sometimes is limited. And then we shoes. How already does it in preferably lace up shoes, so that if you are too tight, you can loosen them up. So you can actually lace up, try to get soft leathers, try to ask, you can even come to your podiatrist to ask, I'm having a problem, you are controlling it, and then the other main thing is, when you grow up, prevention is better than cure. Anything that you see, this could lead to a problem. especially because another thing about any condition that you can takes long to heal. It takes long to heal. Sometimes these peripheral neuropathies, maybe level of vitamin B12 or what, we can reverse them. But if you wait where the damage is continuing for long, it's a problem. And ultimately, the number one thing to protect them out how we check together, well-controlled diabetes, and even if you have high blood, cholesterol, but some anemic, all those conditions, sometimes they do the same thing as tricky. So when you have all of those things happening in the body, it's too much. Another thing, polypharmacy. Especially for call it diabetes, you're already taking your medication, your high blood, that then you take 4. Then you go buy extra things. And then another problem with polypharmacy, so what happened like Panado A white, when I'm red. And then that's why now all my patients get a bring your medication for your first consult. So that if you're already on pyridoxine, I don't repeat pyridoxine. Because sometimes patients are like almost that's what they say. So other than honest, because the pills are already knowledge of not only because of this medication won't come. So another leading cause here peripheral neuropathy polypharmacy. So this is the whole this guy and that the arms are high blood, maybe no right, they can no farm press, I just want to please. But I figure get some time, but it's not the same thing. We find that some of these neuropathies actually come from the treatment. Okay.
Niyazivela polypharmacy le treatment umuntu azathi senginekhabethe eligcwele treatment uthi uyabuka kule khabethe ugcwele into ezirepeatayo and uyaphuza uthatha ngapha so mbukeli lapha ekhaya polypharmacy yiyo futhi elindela kule peripheral neuropathy sesiyayixoxa manje ngifuna uchazele odokotela ama-colleagues ethu ukuthi kungani kubalulekile ukusebenza multidisciplinary kungani kubalulekile ukuthi sithumele ama-patient kunina kusese-AS occupational therapist.
The human body is very complex.
Yes.
And whatever we're studying in our own respective fields within the health profession, it is specific to what we've been trained to do. Does it make sense?
Yes.
And pulling in expertise. So I'm seated here, I'm listening to a podiatrist, pharmacist, and a dietitian. I'm learning so much just within this session of things that I don't know, right? Because you can never say within the health professions you know. I always say that the most dangerous health professional is the one that they think that they know. Central to what we're doing is a patient getting better. And also what is critical is the early intervention of whatever that we're doing. Because what happens sometimes is that abantu bayatreata bagule. By the time they are referring, there's little that you can do. And once you start taking history to a patient, you feel like there's been so much missed opportunity to totally reverse the conditions that we have. So by not referring, you are not necessarily taking now out of a job more than you are actually impeding or delaying or disrupting a total recovery in the patient here. When in doubt, pick up a call and say, within your scope of practice, do you think that there is something that you can do to assist this patient? If you're not sure if an OT or a podiatrist or a dietitian can actually intervene. But the most important thing is that it must happen as early as possible. And also sometimes, because you see a high number of patients within a very short space of time, you'll find that then in therapy, there is so much time that is allocated to a patient that stuff that has been missed during consultation actually comes up. And now we are then able to say, actually, doc, I think we're dealing with this more than this because I've spent almost 2 hours observing this person doing their work. I'm picking ABCD, and a lot of diagnostic clarity then comes in during that process. So I think that a lot of conditions are manageable, a lot of conditions are reversible. From your neurological conditions, I mean, things have changed since during our training. There's certain conditions where you're told that if it's a spinal cord injury, upelile, and so on and so forth. There's new treatment techniques that are coming in, but the early intervention becomes critical to say that we treat these people as soon as we possibly can. And just also in conclusion, the issue of multidisciplinary treatment is not having a file, and then you forget as a doctor, and then you say, multidisciplinary treatment is when the group of health professionals actually discuss and share their insights within a single particular case to say, what is your approach? What did you see within your consultation? And that is what a multidisciplinary approach is, not a single person being seen by a group of health professionals at different times. It is the interaction and the sharing of skills and the combined clinical reasoning that actually is effective and for a better patient care.
Wayicacisa uRithabile okusho khona ukuthi singabodokotela singabahlengikazi and different specialists asingagodli ama-patient asingahlali ne-patient until izixake ukhona usuyithumela kwabanye. The more si-involvana sisonke sisebenza sisonke nge-patient yinye yilapho ezokwazi ukuthi i-patient ithole usizo ngokuphuthuma ingakaze i-complicate. Uthe omunye ebhala lapha ku Facebook wathi ukuthi ngina 15 years ngihleli ku practice akusho ukuthi I'm an expert on that. So siyabala lapho nisale kahle siphinde sitholane next week same time 9 o'clock ngoSaturday ezempilo zomondakalo nisale kahle babukeli emakhaya.
Bye.